Hi, Dr. Reagan Robertson, CCO of Productive Dentist Academy here, and I have a question for you. Are you finding it hard to get your team aligned to your vision, but you know you deserve growth just like everybody else? That's why we've created the PDA Productivity Workshop. For nearly 20 years, PDA workshops have helped dentists just like you align their teams, get control of scheduling, and create productive practices that they love walking into every day. Just imagine how you will feel when you know your schedule is productive, your systems are humming, and your team is aligned to your vision. It's simple, but it's not necessarily easy. We can help. Visit productivedentist.com/workshop. That's productivedentist.com/workshop to secure your seats now.
It's taken many years for you to grind through the hardest substance in the body, which is enamel, but now you're into the soft part of the tooth. And I've seen somebody grind teeth away, a millimeter every year and a half or 2 years, as opposed to small tenths of a millimeter when they're going through their enamel. So it's something that absolutely has to be part of our diagnosis and treatment plan.
Hello, everyone. This is Dr. Bruce B. Baird, and you're listening to the Productive Dentist Podcast. In this podcast, I will give you everything that I've learned over the last 40 years in dentistry, working with thousands of dentists. I'll tell you, it's not that my way is the only way. It's just one that has worked extremely well for me, and I'd love to share that with you so you too can enjoy the choices and lifestyle that productivity allows. More time for things you love, increased pay, better team relationships, and lowered stress. Let's get into it with this week's episode of the Productive Dentist Podcast.
Hello, this is Dr. Bruce Baird again of the Productive Dentist Podcast. We're going to continue today with the risk factors and the things that I work with my patients on so that they understand that it's their problem, not mine. It was, again, an epiphany when I heard John Coy speaking about this several years ago, or many years ago, and it really wasn't about the risk factors. It just became in my mind, oh my gosh, it's not all my fault. And so today we're going to talk about functional risk. And functional risk are those patients that are grinders, clenchers, that carry their stress with their teeth and the muscles related to that. I always ask the question during seminars, I go, how many of your patients do you think need to be wearing occlusal guards? And I have answers from everyone to 90%. I don't know what the actual statistic is. I just know that if you just look at the amount of anti-anxiety medications that people are taking and weight gain that people are seeing across the world, and in particular in the United States. And what does that have to do with anything? Well, that's one of the other risk factors that I'll talk about, which I call physiologic risk. But when I'm looking at these cases, and you see severe wear, these patients can have all types of symptoms, and it can be from TMJ pain to limited opening. And we use a couple of different types of appliances when we're talking about patients who are bruxers. The NTI, which many of you are familiar with, I've had very good success for migraine sufferers by using an NTI. But truthfully, I've also seen some changes in their bite, in their anterior bite, with opening of the bite and shifting of teeth. I think these patients are, in particular, real strong clenchers, and they put a lot of pressure down. You see the wear on the NTI. Then there's the opportunity to use a full arch occlusal guard or a night guard. I try to explain to patients, and I always tell them kind of the same story. I just say, they tested my bite back in 1976. The average person bites at around 125 pounds per square inch, and I bite at over 1,000. And I tear stuff up in my mouth. I've got extremely strong jaws. So, I've torn up crowns. I've fractured a tooth, actually 2 teeth, just with clenching and grinding. I'm much more of a clencher than I am side-to-side grinder. I don't see a lot of wear with my own personal teeth. But you see those patients they've got the huge masseter muscles you just look at their face and you know they're a grinder and a clencher. Or you'll ask them questions, and when they swallow, you just watch the masseters and the temporalis muscles along the side of the head just bulge. So you can kind of tell. Also, when you take a CT scan or a pano, you can see bone density that is, extremely dense. Those are the things that you have to start thinking about. But when I tell patients, I said, tell them that story that I bite at 1,000, and I tell them, you probably don't bite at 1,000, but you're probably biting at 400 to 500 pounds per square inch. Or you have wear of somebody who was born during the Civil War. In other words, if you were alive for 150 years, that's how much wear you have on your teeth. And it's taken many years for you to grind through the hardest substance in the body, which is enamel, but now you're into the soft part of the tooth. And I've seen somebody grind teeth away, a millimeter every year and a half or 2 years, as opposed to small tenths of a millimeter when they're going through their enamel. So it's something that absolutely has to be part of our diagnosis and treatment plan. When you look at dental implants, we know that implants don't have a periodontal ligament. They're rigid, they're fixated, they are the bone has grown to them. They are like an ankylosed tooth. They don't have that ligament. So when you squeeze your teeth together, the teeth have, again, what I tell patients is kind of like God gave us our own shock absorbers. And so what happens is these teeth will intrude, but the implants won't. And it's very, very important, as well as with occlusion on implants, which I use a T-scan, so I can watch the teeth hit, and then the last thing hitting I want to be the implant, but also I want my implant patients wearing an occlusal guard. Now, one of my favorite appliances is actually what's called an E-appliance, and I can get you more information on that. Just send me an email, bruce@productivedentist.com. But the E-appliance is an upper and lower appliance. It's fairly thin, but it has a pyramid in the anterior. So it helps my full mouth rehab patients, my implant patients. And what happens is it's kind of like an NTI, but it's an upper and lower. My patients love it. And you would think, oh my gosh, having to wear 2 of these is much harder and much more difficult. Well, that's not the case. That's not what we found in clinical practice. So by them wearing the NTI, an NTI modified, which would be full arch upper and lower with a pyramid in the front, which is adaptable to when they go into protrusive or when they bring their jaw back in, retrude it, they're always touching on that pyramid. So they're given pretty much free rein, but also the teeth are fixed and they're not moving around. So that is something that has become extremely beneficial for my patients. I charge about double what I charge for a regular occlusal guard. But when we're doing full mouth rehabs, or they have TMD problems or TMJ issues, I really like that appliance. And what do we do for these patients restoratively when they have, when they're a bruxer or when they're a clencher? Well, those are 2 different situations. The bruxer is that one that you see, they may have had cuspid rise at one point in time, but now all of a sudden those cuspids are just getting wiped out. And it's very interesting when you're trying to make the determination, is this normal function or is this parafunction? Just get the patient to say, touch these 2 teeth together. Touch your, upper and lower eye teeth together, and we get a mirror out. They don't even know how to do that. It's kind of funny. You look at them, they're doing like, no, I don't ever bite like that. Well, that's parafunction. What you're doing in the nighttime when you don't even know it, you're sliding that jaw way to the side. And see what happens? And I'll get them to move that jaw to where it finally does touch. And I said, do you ever do that during the day? They go, no, I don't think so. And I go, okay, well, this is a nighttime habit. The other thing that's very important to understand is when you're helping treat patients that have TMD problems, there's lots of therapy. There's lots of, whether it be injecting with different materials. I'm trying to think of what it is, but anyway, when you're doing that, or you're having them in appliance therapy, Sometimes it's an occlusion related. I will always take these folks and put them on the T-scan and try to find out, are they hitting predominantly in one area or more on one side than the other? But these folks have to be wearing something to protect the dentistry that you're doing. And in the long term, I always kind of get a kick out of it when you ask the patients in hygiene. And my hygienist asked this question, and I asked this question very simply: do you wear your night guard? And they go, yeah, I do. That means they don't even know where it is. That means the thing's probably broken or the dog ate it. And I said, really? Are you wearing it every night? Well, no. Well, honestly, I don't wear it as much. It doesn't feel right. It just, okay, we'll bring it in. Because remember, what I'm doing is, if you're not following through with the risk factors, if the patient's not following through with handling their risk factors, meaning, coming in every 3 months if they're a high perio risk, or not drinking Dr. Pepper anymore if they're a high decay or erosion risk. If they're not doing it, they'll look at you and they'll look at you right in the eye and they'll say, oh yeah, no, I'm still drinking just a little bit. Well, that means, all bets are off. That means my little 5-year guarantee that I talk about is no longer a guarantee. And my hygienists are very well versed at saying, well, you realize that these risk factors are the things that caused your other teeth that God gave you to break down. And Dr. Baird will not, guarantee this work if you're not wearing your night guard, if you're not coming in on your 3-month recare, if you're high perio risk, if you're not, stopping to drink, or if you're not using your carry free. And so these are things that I hold their feet to the fire. Why? Because I'm not going to replace dentistry that is not my fault. The reason it broke, and I'm just not going to do it. And again, I told you guys in previous episodes that, man, I used to feel guilty all the time when something failed. I always thought it was my fault. But the truth is, it's really not our fault. So from occlusion standpoint and from bite, those are really, 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 it's as important as the others. It gives you the opportunity to make your dentistry have the chance of lasting a lifetime. Because if you eliminate these risk factors, there's no reason why your dentistry shouldn't last a lifetime. And our patients, they're frustrated. They're frustrated. They've been going to dentist here, a dentist there, and a dentist here, but they've had a whole lot of different advice given. But most of the time, it's usually an engineering solution. Yes, I can fix it. No, I can't. But not a lot of discussion about whose problem it is. And I think we're missing the boat there greatly. The other thing that when I see somebody who's got severe wear, another thing hits me is this patient apneic? Are they having trouble when they're sleeping? Because you'll see wear on folks who are, in particular, I'll see it in the anterior, where they're shoving their jaw forward at night, trying to get oxygen, trying to get air, and you'll see a pattern like that. I'll also see significant erosion on the posteriors. That's when they're gasping for air, the epiglottis pops and you're getting stomach acid, which is tending to kind of pool around the posteriors. So I'm looking for these signs and symptoms. I also look at the patient and I look at them and say, yeah, they have a 17.5-inch neck, more than likely, maybe an 18. They're a big person. That doesn't mean 100% sure they have apnea, but those are the type folks that if you ask them a simple question, do you snore at night? And they say yes. If someone has a 17.5-inch neck and they snore, they've got a 95% chance of having sleep apnea. Well, that's pretty significantly high. So I know who it is and who it isn't. If it's a female, most females are going to be after menopause, but if they've got a large neck and I'm seeing wear, and I will begin the process of talking to them about apnea, which is the 5th risk factor, and I'll be talking about that in a future podcast. So, just remember, how many of your patients need occlusal therapy or an occlusal guard or something? I would say that we're probably way behind on getting people taken care of. I've had patients that have consistently worn their occlusal guard for 25 years. We've replaced them, and those patients can't live without them. I tell patients, if you want long-term success, for your teeth and this money you're spending with us. I just don't want you to waste it. And so that's where this occlusal therapy is very, very helpful. Patients say, well, I gag on everything. Well, nowadays you can scan. You don't have to take an impression and gag somebody. You can actually scan for these appliances. So anyway, that's our episode this time is on occlusal therapy. If you have questions, feel free to send me a email at bruce@productivedentist.com. I'll answer them on future podcasts where we just have a Q&A on podcasts. So we've been getting multiple questions in, and that we'll see that in the future. So look forward to our next time we're together, and make it a great day. And luck is not by chance. It's earned. So see you soon.
Thank you for joining me for this episode of the Productive Dentist Podcast. If you found this episode helpful, make sure you subscribe. Pass it along to a friend. Give us a like on iTunes and Spotify, or drop me an email at podcast@productivedentist.com. Don't forget to check out other podcasts from the Productive Dentist Academy at productivedentistpodcast.com. Join me again next week for another episode of the Productive Dentist Podcast.